Welcome, everybody, those that are here at Gregorio Marañón Hospital and those of you that are online to our second webinar entitled Living with ALS and organized by the BRAINTEASER project. My name is María Fernanda Cabrera and I am Professor of Biomedical Engineering at Universidad Politécnica de Madrid. And I am the project coordinator of BRAINTEASER, and together with me, we have a series of experts and patients that will discuss today about living with ALS. Our agenda for the webinar will be the following. I will start with a small introduction about the BRAINTEASER project, and then Professor Mamede, that I will introduce him and the rest of the speakers later, will talk about ALS diagnosis. We will have also a talk about personalized medicine in ALS and the symptomatic treatments, and also about non-pharmacological interventions in ALS. In addition, we will have another talk about physiological intervention of ALS patients and caregivers, and we will finalize with a real experience from a patient that is living with ALS, and for that, we have pre-recorded a video. To start with introducing the audience, the project that is funding and is carrying out this research and innovation project, I have just started with a slide that shows who we are, who are the consortium partners that are leading this European initiative. This initiative is called BRAINTEASER, and basically it is an innovation and research project funded by the European Commission that tries to use new emerging technologies, mainly artificial intelligence, that you are hearing about it a lot recently, to provide better care for patients suffering amyotrophic lateral sclerosis and multiple sclerosis. Although the focus of today's workshop will be more oriented to those patients suffering from ALS. So the idea of the project, and we have been doing this research for already 3 years, is the development of predictive and preventive models using these technologies for patient stratification and disease progression. And then we are using these models in order to provide precision medicine and precision interventions to inform patients, help clinicians in decision-making, and also to provide these suggestions based on these recommendations. The BRAINTEASER project starts with a lot of amount of data that are retrospectively stored by the different clinical institutions that are collaborating in the project. So we are analyzing this data to provide these artificial intelligence models. Also, we are basing this research on additional data that are coming from the interventions that we are developing for the project, basically some mobile sensor data, and also additionally data coming from the environment in the form of how the patients are exposed to different pollutants. So in previous webinars, we have shown you how the patient app works, but basically this is an app that is carried by the patient together with a smartwatch and this pollutants monitor that allows to monitorize the activity of the patient in order to collect data to provide these personalized interventions. In addition, medical professionals like Professor Mamede or Dr. Umberto that will give you some hints on this disease are using a clinical tool devoted for them in order to analyze this information and provide additional information that it's given to them through the use of these artificial intelligence models that we have developed. And all this information is being shown and provided in order to create awareness through what we call our community of practice that we invite you to join. And this, in fact, this webinar is part of the activities that we are doing through the community of practice that aims to go beyond the actual developments that we are carrying in the project. And we want to share with you all the tools and all the information that we are developing within the project. So to start explaining you and giving you information on who are participating today in this webinar, I will start with Professor Mamed de Carvalho. He is a neurologist and neurophysiologist at the Instituto de Medicina Molecular João Lobo Antunes from Lisbon, and he's the leader of the ALS unit in the main University Hospital of Lisbon. Then we have Dr. Humberto Manera, and he's a doctor at the Centro Regionale della Universidad di Torino, and he's neurologist and also is an expert in amyotrophic lateral sclerosis. We will have also the presence of Dr. José Luis Muñoz Blanco. He is the neuromuscular coordinator of the ALS unit at Hospital Universitario Gregorio Marañón. We also count with the participation of Mr. Dimitris Georgopoulos from ECA Alliance, and he, besides his role as Innovation Project Manager of ECA Alliance, he is also a mental health expert. And finally, we will have Raquel Estúñiga Domínguez, that she's a patient suffering ELA that has been so kind to give us some hints about the disease she's suffering, and she has answered several questions that to share with you during today's webinar. So without further ado, I give the floor to Professor Mamed de Carvalho. Thank you.
Many thanks. And I would like to thank the introduction by Professor Cabrera. And it's very nice to be here. And I'm going to talk very briefly, I'm going to control the time, about diagnosis in ALS. Diagnosis is a very important issue, and it's really the first step. And for some people, they can question that we are dealing with a disease without a treatment able to halt or reverse the progression of the disease. So the diagnostic time is not so important, but in my opinion, it is, and in the opinion of the patient I have followed over the years, because really a timely diagnosis will prevent unnecessary investigations. Otherwise, the patients will keep doing consecutive tests, and that cause a lot of distress, in my experience, in addition to costs and anxiety to patients and their families about uncertainty on the diagnosis. And because the diagnosis is uncertain, many of these patients are at risk of unnecessary interventions, and in particular surgical interventions. We don't have many evidence about this, or much evidence about this, but at least one paper from our center have indicate that patients that undergo surgery, unnecessary surgery, they progress faster over a certain period of time, and so we have to avoid this. And in addition, if you start treating the patients when they are very advanced, we have lower chances of getting a good result. And not only the patients who are involved in trials, but in everyday life, we have good information that starting with Riluzole, for example, at an early phase of disease progression is more effective than starting in very advanced stages. So for many reasons, I think a rapid and effective diagnosis is an important step in the ALS care. And but early diagnosis is not so simple, because really the presentation of these patients is quite variable. And we have patients with presenting with hand weakness, leg weakness, dysarthria, respiratory impairment, etc. Sometimes drop neck or generalized loss of power, muscle power, or even weight loss with fasciculations and other specific presentations, phenotypes. And so it's not very simple. And the patient, when start with the first limitation, they don't go to the doctor very quickly. We have studied this, and there is a delay between 3 months and 6 months. That depends on the study between first symptoms and the first medical observation. And in general, this first observation is performed by a general practitioner, so a general doctor, who is not used, of course, of observing patients with ALS. So there is a first delay, the time the patient takes before going to a doctor. And then there is another delay, which is related to the doctor decision. And in general, as I have said, is a general doctor. And general doctor, of course, that makes sense. First, think about what is a common condition. I mean, ALS is not a common condition. It's good. And of course, the doctors first think what the most common causes for that problem. If the patient presents with dysarthria, I mean, it's not uncommon for patients going to a dental doctor or to an ENT doctor or another specialist caring about that region. And the patients have hand weakness or arm weakness. So in general, they are referred to a neurosurgeon because cervical cord lesions are not uncommon. And the patient has a leg weakness, and they are referred to an orthopedic surgeon because lumbar spine is thought to be the problem. And if the patient have respiratory distress, I mean, dyspnea, respiratory fatigue, they are referred first to a cardiologist or to a pneumologist. So that makes sense, but that takes time. And so the patient undergo a lot of investigations, and they will arrive to the neurologist later in time. In general, I mean, the median time for diagnosis is about, in most studies nowadays, about 11. This is the median time, is about 11 months. I mean, it's really not very variable nowadays between different centers. We have studied that in another project that we were involved in, a European project named One Web Duals. And we could confirm that there is no really significant variability between different centers in Europe. Although the track of the patients to diagnose is quite different, depending on the particular health system of every country. Anyhow, I mean, over time, maybe there is some saving of that time. One study from Turin, and Roberto Manera is the man that can confirm that. And from Lisbon, it seems that now we are doing the diagnosis 1 month shorter than in the past, but this is not really a dramatic difference. And what is an important step in our experience and our data is going fast to a neurologist. That is important. Although the first neurologist only is able to perform diagnosis about 25 to 40% of the patients. So, I mean, even the first neurologist is not very productive in getting the right diagnosis very rapidly. Anyhow, this is better if possible. And the problem is, I mean, how to go faster to diagnose to the neurologist. And this is really a little bit complicated because, as I have said, the patients are first studied for other more common conditions. And one thing that we have analyzed, what is once observed by a neurologist, what is the most effective investigation for getting diagnosis. And really, I mean, of course, many diagnoses will prescribe or imaging studies, which makes sense. I mean, because we have to exclude other conditions that could be treatable. But the most effective investigation for getting a quicker diagnosis is the electromyography, the neurophysiological investigation, which is very important, very, I mean, it's very easy to understand if you are a neurologist, because EMG, electromyography, is an extension of the clinical examination. The problem is when we are performing clinical examination, we see weakness in the arms, we don't see weakness in the legs, but EMG is more sensitive than our observation for getting signs of lower motor neuron generation of other regions of the body. And so with EMG, we have an extension of our arms, we have a kind of a microscope able to detect other changes. So really, shortening diagnosis is important, and it has been discussed over the years many times. I have been involved in this many times in the past, how to go to a faster diagnosis, and there is no good agreement about that, even because we don't want to dramatize a condition close to the population, because we don't want everyone with a sensation of weakness going directly to neurologists. That would be very difficult, even because the number of neurologists in some countries is quite short, and this would not be a good solution. It has been discussed for a long number of years about the biomarkers, and now we have really a possibility of having neurofilaments as a biomarkers for this disease. I mean, and no doubt neurofilaments measurement in blood in particular can be sensitive way to understanding something is wrong with neurons, but it's not specific. And so possibly this will not be the solution, the final solution for a quicker diagnosis, even because this is investigation that is not available to general doctors. We know, of course, that some patients go to the diagnosis quicker, in particular patients presenting with bulbar dysfunction, dysarthria, dysphagia, because there are many conditions in the differential diagnosis. And so we know from almost all papers confirm that really having a bulbar presentation is associated with a quicker diagnosis. And also the patients with a quicker progression. This is very consistent. The patient who is progressing very quickly, they will get diagnosis in a shorter time, because of course the doctor will be more confident in early diagnosis if you see the progression of the disease over a shorter period of time. Age is another thing, and in general, in our experience and in other studies that has been confirmed, that young patients, they need more time for diagnosis. And this is probably because when we see a young patient with ALS, we are more resistant to define the diagnosis without performing more investigation in order to give more chance to the patient to have an alternative, an optional treatable condition. So really, age can be also a factor to be considered. Differential diagnosis is important. We have now criteria for the diagnosis. The last criteria, which was defined in 2019 in the Australian Gold Coast criteria. They are very simple. In the past, the criteria for neurology were very complicated, and that complication was not very useful for diagnosis. But now they are very simple, and possibly that will improve the diagnosis regarding the time for defining diagnosis. One of the reasons for the diagnosis being delayed is because, of course, this is a difficult diagnosis. The information to patients is difficult. We know that is an irreversible condition, is a progressive condition. So is understandable that some neurologists try to resist to giving the diagnosis to the patient without excluding any other option, sometimes very exhaustively, in order to be confident. And this, of course, will also lengthen the diagnosis time, which is understandable, but not necessarily really very good. And so that's why I think it's important, once the patient is suspect of having ALS, to be observed in a clinical center with a large experience in this condition, because the doctors will be more confident, because they have a larger experience, and that I believe will be better to the patients for that reason that I have mentioned in the beginning. Less investigations that are not very useful, less anxiety, and the opportunity to start treatments and follow up at the early phases of disease progression. How to improve this? This has been discussed. It is not very simple. In the past, there was an experience many years ago by a neurologist who died early in UK, where he has created a green line, a green track for diagnosis in ALS. He could save some time with that experience that did not last for a long time. But I think we need really a kind of fast track for those patients, not on ALS, but patients with what I have suggested in the past. But I understand it's difficult to accept patients with painless weakness. I mean, patients with painless weakness. Because if the patient has weakness and pain, other diagnoses are more probable, in particular spinal cord lesions and root lesions and so on. But in painless weakness and objective weakness, not that subjective sensation of fatigue or weakness, that's a little bit different. But for patients with objective weakness in one segment of the body, that has to be observed by a neuromuscular specialist, because it's not ALS necessarily, but can be a myopathy or motor neuropathy or any other condition. And so one step to improve diagnosis time is really to have a kind of green line for those patients with painless focal weakness to be observed in a neuromuscular clinic very quickly. And those, of course, with suspicion of ALS should be guided to ALS center, where the doctor will be more confident and because they have more experience in getting diagnosis in a shorter time. So diagnosis in ALS is uncomfortable for the doctors, is difficult for patients and families, but getting a faster diagnosis is important for having more chances for responding to treatments that we have, and to be included in trials that we are running or will be run in future, in the brief future, and that permits, I mean, really to understand better the progression of the disease from early phases, and to monitor, for example, respiratory function. This is very important in these patients. So that's my feeling about diagnosis in ALS. And I will finish here. I took my time, and so I thank you very much again for this opportunity.
Thank you. Thank you, Dr. Mamede. It's been very interesting, and your talk, and knowing that what important is to detect quickly the condition, to be, although it's an irreversible disease, to have a better treatment and a better approach to the quality of life of the patient. Thank you so much. So our next speaker will be Dr. Manera from Torino. I think that you are going to share a presentation.
Yes. Okay, you can see my screen. Okay. Okay, thank you very much for inviting me to present this talk. Thank you very much, Professor Cabrera, and to have this talk about personalized medicine in ALS. And I will focus on mainly on symptomatic treatment. I thank also Professor De Carvalho for the introduction, because he explained a lot of concepts that I will use during my presentation. And first, I will briefly remark the fact that some feature of ALS phenotype heterogeneity explain why in ALS field personalized and precision medicine is mandatory, not only for disease-modifying drugs, but also for symptomatic drugs, because patient can be very different. We know that ALS, we already listened that ALS can start and subsequently involve any different body region, can affect upper and lower motor neurons, so it can give to upper and lower motor neuron signs that can be very different. And we don't know why this happens in ALS patients, but we need to be able to cope with many different combinations of symptoms in the single patient. And moreover, we have to take into account that disease keep evolving during time, following different trajectories in different patients. It can pause, especially at the beginning of the disease. It can seem to accelerate in some phases, probably because the sum of functional loss in different body regions gives the impression that the disease also accelerates during time. And we also have to consider that motor impairment is just the tip of the iceberg, because cognition and behavior can be also variously affected in ALS. And more recently, also some non-motor and non-cognitive symptoms have been pointed out as present in ALS in some point during this progression. And considering symptoms, we can make sort of rogue classification. We can consider motor symptoms directly caused by the disease, for example, muscle cramps, fasciculation, but also, for example, sialorrhea, which is the augmented saliva in the mouth, which is directly related to the swallowing impairment. We can have also non-motor symptom caused by reduced motility. I will speak a little bit about that, but the next speaker will speak about physical therapy in ALS. And we also have to consider that we have non-motor symptoms not related to motor impairment and reduced motility. And we have to consider, for example, also emotions, anxiety, loss of appetite. This is a classification that we have to keep in mind, but we have also to forget it, because in the majority of patients, the symptoms that we have may be related to a combination of different causes. Okay, let's talk about treatments. So, considering that I will focus mainly on, you listen? Okay. Okay, considering that I will focus mainly on drugs, I have to declare that I have nothing to disclose, and I prepare this talk using as a main reference the European Academy of Neurology guidelines on ALS management that were recently published on the European Journal of Neurology. I will start with muscle cramps. So muscle cramps are certainly one of the most common and annoying symptoms in ALS patients, because they can be also very, very painful. And what we need to understand is that to resolve muscle cramps, we have to break or reduce a sort of circuits between motor neurons and also between motor neurons and muscles. And we have many weapons to resolve these short circuits. One of the most important drugs that we use is quinidine, which is a first-line drug that is derived from cinchona, which is a tree, which is a root. It's quite interesting because it's the same root that is used normally to give the bitter taste to tonic water. Is a drug, certainly, is an anti-malaria drug, but is very useful for cramp because it acts also on muscle excitability. We just need to pay attention because it's a drug that affects also heart conduction, so we have to pay attention and to monitor ACZ using these drugs. As you can see from these slides, the majority of drugs are mainly based on anti-epileptic or myorelaxant drugs, except for the mexiletine, which is an anti-arrhythmic drug. Cannabinoids are recently studied also for cramps, but unfortunately, for example, the dronabinol, which is a cannabinoid, which can be considered as a second-line drugs for cramps, is available only in US. In Italy, we have the approbation of the damixibol, but just for spasticity, so we don't use it, for example, for cramps therapy. I just want to mention about among the different myorelaxant, the clonazepam, which is a very diffuse drug, and we use it a lot, especially for nighttime cramps, because at very low doses it can be very effective as a myorelaxant, and is also a therapy that can treat both nighttime spasticity and insomnia. Fasciculation is another very common sign of ALS. Unfortunately, there is no specific treatment for, according to guidelines, for fasciculation. And we have to consider that fasciculation are not a very annoying symptom for a lot of patients. So my advice is to treat fasciculation only if the patient report them as very annoying. There are again some myorelaxant or anti-epileptic drugs that can be useful for fasciculation and for cramps. And some patients report benefits, for example, in the use of propranolol, which is a drug that reduce the adrenergic activity and reduce also anxiety related to this fact. We have just to pay attention because it can reduce the heartbeat frequency and can cause hypotension, but again, at very low doses can be useful for fasciculation. We also have to consider and to advise the patient to reduce excitants, for example, the amount of caffeine, and to treat also the anxiety related to that. Okay, spasticity. What we have to do to cope with spasticity, we have to reduce the muscle tone. Spasticity is an increased muscle tone, so we have to try to reduce muscle tone. Another advice is to treat spasticity, especially when the patient report as painful. Spasticity is very painful because considering that motor neuron is a mixture of upper and lower motor neuron signs, we have to understand that spasticity can also help some patient in maintain normal abilities, because we call it in Italy the crutch effect. So the spasticity can be very important to reduce the risk of fall and traumas, because if we reduce too much the muscle tone, we can cause a higher amount of falls and traumas for patient. Also for spasticity, we use mainly myorelaxant and anti-epileptic drugs. And in Italy, we have as a second-line treatment also a cannabinoid, which is the nabiximol, which is the Sativex, which is approved for the treatment of spasticity in MS. But in Italy, we can use it also for non-responsive spasticity in neuromuscular disorders, so in ALS, in spastic paraplegia, and in other conditions related and characterized by spasticity. Secondary pain, which is the pain due to reduced motility, is an very important determinant of quality of life in ALS. The first line is certainly physical therapy, but pharmacological therapy can be paired with physical therapy using mainly anti-inflammatory and analgesic drugs. And for articular pain, intra-articular injection of steroids is one of the first-line approach that we use. And as I mentioned before, sialuria is mainly related to impairment swallowing. We are unfortunately not able to fix swallowing in ALS, but we can reduce the production of saliva. So this is how we treat this symptom. And to make this, we practically use side effects of some drugs that these drugs have on acetylcholine receptors that are present on saliva glands. And so we use, for example, a lot of different drugs. For example, amitriptyline at very low dose, atropine, which is quite interesting. In Italy, is mainly used as an eye drop therapy, but we use orally, for example. We use glycopyrrolate, which is used for treat patient with asthma, but we again use this side effect to treat sialuria, and scopolamine and oxybutynin. We have to pay a lot of attention, a great attention to the most common side effect of this drug, which is constipation, which can be also a symptoms which is can be very harmful in patients with ALS. So we have to adjust the doses of the treatment according to this symptom. We have to advise patients to avoid some kind of food, for example, to reduce sialuria. And also as second line therapy, we have botulinum toxin, which is directly injected into a salivary gland to reduce saliva production. And in very, very, very few cases, we also have the indication to perform radiotherapy. The problem with radiotherapy is mainly related to the fact that not so many patients are able to stay still in some position to make radiotherapy, and also radiotherapy can be painful for some patients. So it is a third line kind of therapy for very, very severe cycloria. Speaking about non-motor symptoms, emotional lability is certainly the most common symptom in ALS. It's important to ask if it's present and if it hurts, because it can be a symptom that the patient did not perceive as a problem, as harmful. We also have to explain the patient that to stabilize the emotion can also in some way stabilize some motor aspect, can improve motor skills, because especially considering upper motor neuron sign, we know as a neurologist, and also because patients tell us that emotion play a great role in functionality. So we can decide and we can explain that giving some drugs that can stabilize emotion lability can also have an effect on motor performance. And we mainly use some drugs that are the antidepressant drugs and that works on the levels, the brain levels of serotonin. So they act on it, improving certainly mood, reducing anxiety, but also stabilizing this emotional lability. Unfortunately, there is also a combination drug that is not available in Italy, and I also asked to Professor Mamedov, I think in all Europe, which is the dextromethorphan quinidine, which is unapproved, is the only approved therapy for emotional lability. We have also to investigate other common emotional symptoms such as depression and anxiety, because we can treat them using, for example, just one drug to solve all this kind of problem with patient. For example, antidepressant can be very useful for patients that reports also anxiety, because they are the first-line therapy for long-term anxiety. We have to pay attention if anxiety, for example, is combined also with insomnia, because insomnia can be one of the manifestations of anxiety and of depression, but we have to investigate insomnia in patients, because we have to exclude that is not related to respiratory symptoms and to hypoventilation or to motor symptoms, because nocturnal cramps are very, very frequent in ALS patients. After excluding all this kind of troubles and to treat respiratory symptoms and cramps, we can treat insomnia mainly using anxiolytics and drugs that and sleep inducer drugs. We always start at very low doses and then adjust, because we all know the complication of these drugs, that is daytime drowsiness, daytime sleepiness, and we want to avoid it. And again, for example, we can use drugs that can be able to affect many different symptoms. For example, clonazepam now is active on cramps, on insomnia, on spasticity. So it is a drug that we use a lot, for example. We have to pay attention to constipation and stiffness, because guidelines explicitly say to actively assess its presence in ALS patient, because it is a very common condition that we sometimes did not investigate so much in patient. First of all, we don't need to use drugs to treat this symptom. We have to increase the water and fiber intake. We have to stress the concept of regular mobilization for patient. We have to pay attention, because to treat other symptoms such as cyalorrhea, we can cause or pain, we can cause or worsen the constipation. But we have to, then, if the constipation is present, we have to use some specific therapy. And what we use most in ALS patients are very well-tolerated drugs, such as osmotic laxatives. Another symptoms that we have to investigate actively, because it's not so frequent that the patient report, is also the loss of appetite. The loss of appetite is quite interesting because recent studies have demonstrated that it's very common also in patients with a spinal disease, not only with a bulbar disease, so with a swallowing impairment. Is an important symptom to analyze, because it can be also related to some other aspect of the disease. Is related to the worsening of the disease, is related to the respiratory impairment. What we first have to do is, as a doctor, we are pretty happy to do that, because the patient are also happy to listen what we say. We usually advise the patient to eat everything that other doctors tell them not to eat. So because we don't say it just like that, but there are some recent studies, for example, that some diets with a higher glycemic index and a higher glycemic load can be very useful also for the disease. And we can use some side effects for the antidepressant, because antidepressant can improve also the loss of appetite. Okay, and finally, fatigue is unfortunately present in almost every patient with ALS. Fatigue is a symptom that can be related to many different causes. Unfortunately, there is no a specific treatment for fatigue in ALS. But we have to understand what are the underlying cause of fatigue, and to treat the specific cause. We have to pay attention, because riluzole, for example, which is the most important disease-modifying drugs in ALS patient, can also be one of the cause of the fatigue. And some patients cannot well tolerate riluzole, reporting a worsening of fatigue as one of the most common side effects of these drugs. And we have also to understand that patient can experience during disease progression also breathing symptoms, symptoms related to the lack of breath. And certainly the first line treatment is non-invasive ventilation in this patient. But we have to consider that we have some drugs that we can use in combination with non-invasive ventilation, and mainly these drugs are opioids. Opioids can be used at, for example, at very low doses, can be very useful to solve the sensation of loss of breath, and can also help the patient to better adapt to the ventilation in some cases when the ventilation gives the patient a lot of anxiety. And we can use, for example, also some short-acting anxiolytics to treat respiratory symptoms. Okay, considering all these different symptoms and their evolution, BRAINTEASER app, what we are doing within this project to develop the BRAINTEASER app can be very useful for patients, for caregivers, for nurses, for doctors, because as a general rule, the first we know that the patient experience a new symptoms, the better we treat. As Professor De Carvalho said, the first we diagnose, the better it is, but also the first we recognize and diagnose a new symptoms in ALS patient, the better we were able to cope with these symptoms with therapies at the right time, at the right dose, and without exposing patient also to some risk related to treatments. And I will thank again Professor Cabrera for this opportunity, and all my colleagues in the BRAINTEASER project, and you for your attention. If there are some questions, I don't know if there is the moment or later. Thank you very much.
Thank you. Thank you, Dr. Manera. It's very interesting to know that there are several drugs to treat symptoms, and how important also the role of BRAINTEASER in terms of this app that we are developing to detect and identify new symptoms to could treat in a better way the patients. Our next speaker will be Mr. Dimitris Georgoulis, and he will talk about the psychosocial interventions for these patients and also the caregivers. The floor is yours, Dimitri.
Thank you. I hope you can see my presentation. Right?
Yes, we can.
Okay. So the gradual loss of motor function significantly impacts the quality of life for ALS patients. Research findings underscore the importance of tailored interventions to enhance the overall well-being of individuals with ALS. Such interventions encompass multidisciplinary care, psychological support, and the incorporation of assistive technologies. Addressing the multidimensional aspects of well-being is crucial for providing comprehensive care and support. Family members often become the primary caregivers for ALS patients, assuming the responsibility for their daily care and well-being. The complex and progressive nature of ALS can have a profound impact on both the physical and psychosocial well-being of patients and their caregivers. Caregivers may witness their loved ones' gradual deterioration, causing emotional distress. Additionally, the demands of caregiving can lead to physical and mental exhaustion, often resulting in caregiver burnout. This impact extends to the caregiver's health and well-being, potentially jeopardizing their ability to provide effective care and affecting family dynamics. Psychosocial intervention refers to any attempt to provide solutions to the challenges individuals may encounter in terms of psychological well-being when interacting with any element of the social environment. Psychosocial care includes a spectrum of services and therapies spanning from educational interventions that systematically provide information to intensive one-on-one counseling sessions. Psychosocial interventions often combine multiple components to tailor the approach to the specific needs of each individual and their family. Psychosocial and emotional support for patients and caregivers is fundamental both in the moment of clinical diagnosis and during the disease progression till terminal stages and death. We can define 3 topics of psychosocial support in ALS based on the different stages of the disease, where patients' experiences have different emotional and behavioral conditions. First is the initial coexistence with the disease. Second is the therapeutic decisions. And third is dealing with the end-of-life stages. Next, we will see how these stages are addressed in 3 different areas of intervention: in the hospital, at home, and within health groups. So, in the hospital, the first psychological interview aims at assessing the following aspects: the patient's emotional experiences, the relational dynamics, patient's resources, and personality traits. Emerging elements may become a useful source of information for physicians, contributing to building a more effective and customized communication process. Psychological sessions for patients are structured into a care route arranged for the medical team working on the patient's case. Sessions include different approaches: assessment interviews, psychometric and neuropsychological evaluations, psychoeducational interventions, support and mediation counseling. Dealing with end-of-life decisions is complex and distressing for both patients and relatives. Any care option in the hospital during the late stages should respect personal choices and individual time necessary for psychological elaboration. Psychologist intervention at home may occur after a care team suggestion or a patient's or a family's request. Psychologists first take the continuity of medical and social assistance, then assess needs and collect the patient's clinical history. The psychologist supports patients and their caregivers through the organization of daily living. Psychological interventions during the progression of the disease consist in 1 or more psychoeducational sessions, psychological support, and mediation. The aim is to restrain the distress and to reinforce the resources of the context. After hospitalization, the process of decision-making should proceed at home. Doubts and fear could emerge during this time, and evaluation of the comprehension and elaboration of the information provided by the physician during hospitalization is important at this stage. It is important to highlight that health groups do not substitute individual psychological support or psychotherapy, which are recommended in case of severe psychopathology diagnosis or distress. Within help groups, the psychology acts as a communication facilitator who engages patients, caregivers, and families. The psychologist promotes empowerment and autonomy of each member with the aim of developing individual potentials using the group as the main resource. As the disease progresses, patients with ALS experience a loss of autonomy in daily life activities, becoming more dependent on their caregivers. Often, relatives assume primary responsibility for the complex care needs of patients in non-medicalized settings, and in this regard, ALS has been described as a family illness. Informal caregivers have a key role in the process of decision-making. However, the role of caregiver can be a very demanding and overwhelming activity for relatives. They often experience heavy care burden and may develop somatic symptoms and psychological distress, leading to implement coping strategies to remove, reduce, or manage stressful situations. The well-being of caregivers is crucial for a careful management of chronic diseases. A high level of burden may lead to a breakdown in care and to an earlier placement of the patient in a care home or hospice. Caregiver needs are dynamic in ALS as they change following the disease progression. In this regard, the trajectory of the ALS caregiver's needs can be represented by a full cluster map. First, we have early coping and adjustment. Then we have maintenance. Third, we have transition to end stage. And fourth is coping with change and loss. Now let's see what are the most important needs of informal ALS caregivers. It is very common for both patients and caregivers to need education on ALS management in terms of the disease itself and about caring for a person with ALS. Many caregivers express the necessity of more personal time. Most relatives who are informal caregivers adapt their lifestyle to that of the patient and reveal that they tend to neglect their own needs and focus on the patient's wants instead. Being able to leave the house and spend time on their own activities is important for maintaining their own well-being and allows caregivers to temporarily divert their attention from ALS. On the other hand, caregivers experience difficulties in handing over care to others, which often causes distress rather than relief. Additionally, when they use paid home care, they are confronted with reduced privacy. So, despite the need for specific psychological interventions for caregivers, there are relatively few studies addressing this topic. Recently, David and colleagues proposed for the first time a blended intervention based on acceptance and commitment therapy, which is a cognitive behavioral therapy that encourages individuals to accept events that are out of their control and to identify important values in life in order to engage in committed action to pursue these values. The support program consists of an introductory face-to-face appointment with a psychologist, 6 guided online modules, and a concluding phone contact with the psychologist. Caregivers that benefited from this support program reported the following mechanisms of impact. First, perceiving control over the caregiving situation, including specifying boundaries and creating time for themselves, asking help from professionals and social networks, and preparing for the future. Second is accepting negative emotions and thoughts, meaning expressing and allowing emotions and recognizing that others experience the same emotions too. Third is being there for each other, communicating about difficult topics, emotions and thoughts, better understanding partners' needs and emotions, and undertaking activities with the partners. And last but not least, feeling acknowledged, receiving attention and feeling understood, confirming that they are doing things right, and devoting time to themselves by working on the program. So this is all from me. Thank you very much.
Thank you, Dimitris. We have seen that it's, sorry, we have some echoes in the room. Okay, it's all, sorry. And one of the, another important part of what we are doing in the BRAINTEASER project is the intervention part in terms of what kind of additional tools we can provide to patients in order for them to cope with these associated mental health problems that could appear. So I think that your overview on these problems is really relevant.
And this is the aim of the community of practice, of the BRAINTEASER Community of Practice, to provide resources. So we will share the link in the chat for our attendees to visit and check our resources.
That's great. So this is just for the audience to understand that this is an important part of what the community of practice is trying to do. Not only providing the technology and the research and innovating, but also sharing and creating awareness and provided new solutions for the patients and obviously the caregivers that in this is a very important part. We have a video from one of the patients that we have interviewed for this specific event. Her name is Raquel Estúñiga, and we are currently sharing the video. So I leave the floor to Raquel. I would like to thank Raquel for allowing us to record this video and understand more the problems patients with ALS suffer. I would like to ask the panel that are here today with us if how do they feel that BRAINTEASER in their particular fields that they have presented is helping professionals in the, let's say, treatment and better decision taking in their daily clinical practice with this kind of patients. I don't know if Professor Mamede or Umberto, you can add something about how with this project we are coping and making really an innovation in how this the quality of life of these patients can be improved.
So I can start very quickly. I mean, I think we have two dimensions here. One is a more human dimension, another more technical, which is very important because medicine is also a technical discipline. And so regarding this, the more human dimension, I think is the easy contact or a closer contact with doctors and the healthcare system. So the patients, usually they are observed in the clinic every 3 months or so. And of course, they can touch us when they feel it's necessary. But with this process of the BRAINTEASER, the patients have the opportunity to have a more constant, continuous contact with the team. And this is very comfortable for them. They feel more care, more followed by the doctors and the health team. And so it's very important from the human point of view. And for them is really, I'm sure, very, very reassuring. Another point is more technical. So we can get more information about the patient's condition. I mean, for example, we can see the oximetry, and we can improve this in the future. We can see how they are feeling. We can see how they are moving and so on. So we have the possibility to analyze and to follow a number of physiological information from the patients. And this is, very useful and can be even more useful in future, of course, when we have the tools to analyze this more automatically, providing a more linear result for understanding. But anyhow, this is a technical information that can be very useful, and we can understand if the patient is not going well because the information or the data we receive is different. And so this technical part is going to be refined for sure, but is also very, very important when dealing with these patients with rapid progression.
Thank you. Umberto, do you want to add something?
If I can add and complete, I completely agree with what Professor De Carvalho said. And another thing that I am in mind that technical and human part can are joining this project. It can be very helpful for doctors, especially let me explain, in modern times in which we have a lot of time problems, and when we see a patient with ALS, we have to maintain and to maintain our and to fully concentrate on the human relationship between the doctors and the patient, but we have to maintain also our technical abilities. And BRAINTEASER has the great opportunity to give us the possibility, for example, to much deeper analyze and also to reassume a lot of data about disease progression, about what really happens in patient routine life. And we also can be better prepared to and to have much more time also to concentrate during the visit on the human part, because what we listen from the directly from the patient the patient speech, at least finally the patient much more concentrate on the human aspect. The technical aspect is very important for doctor, and we know that we have to give drugs to improve quality of life, but what the patient perceived during the visit is much more the human part. And the problem is that sometimes, even if in Italy is a recent law that says that the time of communication is time of care, we today every day cope with the lack of time to in routine in daytime visit. So BrainTeaser, which can also be a great help for doctors, because is an instrument to have much more information, much more help in less time.
Yeah, this is something that for patients and for caregivers to understand that the tools that we are using, especially the patient app, is very doesn't require too many skills to be used, and basically it's an instrument to collect additional data that medical professionals don't have on a daily basis, let's say. So this will help in the visits that we are not in any case removing, but these visits, let's say that the treatment protocol continues in the same way that it was before, but you get additional information that could help you in determining the new phases of the treatment in order for the patient to be really better care, let's say. So I can see that there is a hand raised from the audience, but I don't know how to give the floor, or if this can be done. Maybe the administrators, they know. I see Pavel. Okay, it's not anymore raised. Okay, it's done. So what is important also for the audience and for the people that hear is that we are doing these webinars, and these webinars are going to be uploaded in the community of practice. So for you to understand that this is a tool that we are feeding with content, with information, with talks from professionals, from experts, from patients, that will help you in some aspects to understand aspects of the disease, or to know latest treatments, or, as Professor Mamede said at the beginning, new trials that could come, etc. So from the BrainTeaser project, we are doing our best to create awareness of all that we are doing, and also others. So we are promoting news and activities through the community of practice. So I know that Dimitris already shared the link in the chat, but so you can register and get further information about the BrainTeaser and the community of practice. So thank you for being here today, and thank you to the panelists, and thank you to the audience and the people that are here present with us at the Hospital of Madrid. And see you soon in our next webinar. Thank you so much.
Thank you very much.
Bye.
Great
Bye.
thinking.
Thank you very much. Bye.
Bye.